Well, welcome everyone. Welcome to Friday's report out. It's good to see you all. Delighted that we've got another excellent lineup, and particularly pleased that we've got Sean talking to us about the multidisciplinary teamwork in acute and elderly medicine. I had the good fortune and benefit of seeing this firsthand with Ali and Sean and colleagues recently, so looking forward to this. So Sean and Ali, I can see Ali, over to you guys.
So I should say it's myself and Abby Flinders presenting today. So I'm gonna do the first few slides and then I'll
excellent. Good. Welcome, Abby. Good.
She's obviously been doing a lot of this work as well. So let's just see if we can click on. So this is part of a wider trust collaborative that Ali Cracknell's been leading on, called Teamworking for Better Conversation and Better Outcomes. And the bit that we've kind of nominally been focusing on is about better MDT conversations. But I'm going to talk a bit more about the extra things that we're doing as well. This is where we sit within the whole program. So the whole program is about improving patient experience and improving how MDT members feel valued. And like I say, the focus for us has been about this bit here, about optimizing MDT working. But we've also been doing some things about kind of knowing the patient as well as knowing each other. So I'm lucky to have lots of close friends that I have very good conversations with, but I'm sure many of us will have had bad conversations. And I remember earlier this year speaking to one of my old friends who hadn't seen for a while during the pandemic, and he was telling me how he was struggling because he had to work from home and he had 2 kids at home, and it was all very difficult. He obviously, like many of us, hadn't seen many people for long periods of time. And he turned to me and said, after I'd listened to all this, and he said, well, I guess it's not been that much different for you, has it, Sean? Because I think he thought because I was going to work and because my kids were still going to school that the pandemic was just the same for me. And I had to point out to him that actually I've been working on a COVID ward for 9 months, seeing people of all ages, just with one disease, with lots of death and destruction. And actually it was very different to what I was doing before. And sometimes these conversations can happen at work as well. So we're talking at each other rather than talking to each other, and that's kind of one of the problems that we've been noticing at work. This can happen in team meetings as well. So I'd say a bad MDT meeting might look like somebody talking quite a lot and dominating others, maybe not listening to what other people are saying. Sometimes things will happen like the nurse will say this patient's more confused than normal. And the doctor will say, well, when I saw them, they weren't confused. And the doctor will say, this patient needs a physio assessment. And the physio will say, well, this patient's walking and doesn't need a physio assessment. And there can be a clash there that can be quite uncomfortable sometimes and doesn't lead to good working. And Richard, who's one of the senior physiotherapists in the elderly medicine department and also the manager of Otley Town Football Club, did a lot of great work on this, just understanding what the problems were. By kind of watching MDTs and recording the time taken, but also gathering lots of feedback from both physios and from doctors. And there was a lot of unsatisfied people, not happy that MDT conversations were going well. And there was even people saying things like that they thought it was like the worst time of day and they didn't want to come to MDT meetings. So that was a big problem for us, that we weren't talking to each other properly and our meetings weren't very successful. And I think sometimes that happens with patients as well. So, you know, I've certainly overheard conversations where people say things like, oh, it's medically fit, there's nothing wrong with them. And then the relatives are unhappy. And likewise, the opposite issue can sometimes happen. So I had a patient this week who I was on their 4th day of intravenous antibiotics after coming to my ward from other wards. And actually had previously said that she didn't want to come to hospital at all. And when we gathered out a bit more about her, she's a very independent woman who'd done a PhD in her 60s and had clearly expressed that the life that she would be leading now, which was of very low quality to her, wouldn't be something that would be meaningful for her, and she wouldn't want to be admitted to hospital. And this was all very clearly explained by the son. But when she'd come into hospital, we were just going down the kind of medical model of doing the next thing and doing tests and giving IV antibiotics. And we need to have better conversations with our patients as well. So as well as kind of looking at the MDT work, what's really important is us knowing our patients. So this is Ken Rockwood, who's a kind of eminent geriatric researcher, and some of you may have heard of the clinical frailty scale that we were using during the pandemic, and it was used as a kind of potential rationing tool then. But what he was talking about was understanding that two 85-year-olds may be very different. One of them may be very dependent, but one of them may drive a car, work, look after grandchildren. And for us to kind of provide good care, we need to understand what people are normally like and how much they've changed. And that can be quite sad sometimes when you're in hospital and you're trying to explain to the rest of the MDT. I've noticed this more on kind of outlying wards than our own wards. We're trying to explain that this man used to drive a car and walk independently, and people say, "Oh no, I don't believe that," because all they can see is a frail old man in hospital pajamas. But actually, there's been a change because the patient's acutely unwell. And that's a really important thing to understand, both in terms of how ill the patient is, but also in terms of planning. I think the other thing is that our systems can be quite confusing. So there's lots of different potential ways of getting people out of hospital in terms of support services. And Abby and I are both lucky to be community geriatricians, so we have experience of some of these services more than other people. But even then, it's still a little bit confusing. And I think for us to have effective conversations about what we're doing for our patients, the whole team needs to understand what these words mean, and that's come out that sometimes people don't understand what these things mean. So I'm going to hand over to Abby for the next slides, but I think that the issues that we've kind of raised here. So I haven't.
You can carry on.
So the issues that we've raised here is that what we need to do is to know each other better, know our patients better, have better conversations with each other and with patients about what's going on, to understand our processes, our discharge pathways, so that we can do what we want to do, which is just get people better and get them home. And I'll pass over to Abby for now.
Hello, sorry we couldn't get both computers working, hence our musical seats. We're quite lucky, I think, in elderly medicine, in that although we've very much, as Sean described, lost some of that fantastic team ethos we had prior to the pandemic, we have been part of teams that are excellent and in being excellent, achieve excellent outcomes. And we know that there's some fantastic work which you've all heard about in the past by Dr. Ruth Burnett, in terms of how exceptional teams work and maintain good outcomes. And this is from one of her presentations, that we know that the safest teams and the ones that get the excellent results are those that know their patients well, and the staff know each other, and they're able to therefore bridge the gaps between those elements. And so, as Sean said, getting to know the team is going to be very important, so that we can have those interactions on a daily basis, where we don't need to be best friends, but knowing just a little tiny bit about each other means that all the conversations become easier with the members of the team. Having better conversations, and as Sean's already touched on, the problems that we sometimes have where we are transmitting the information rather than delivering it a way that's helpful. Is it moving on? Oh, what's happened, Sean?
It's probably just being slow.
It might be being slow. Jimmy, I don't know if you can move that on. It won't move on for me. Thank you. And knowing our patients, and I think we all recognise, that we need to know our patients in order to deliver excellent care. But as Sean's touched on, we also need to know them really well to understand what's important to them, and also to understand their illness recovery. And I think one of the dangers in the medically fit or medically optimised for discharge terminology is that sometimes we can mistake that for that the person is well and back to normal, when actually what we're saying is the person is ready to transition out of hospital to somewhere else, but they may be continuing their illness recovery and rehabilitation somewhere else. So knowing at what point in that cycle somebody is, and the whole team to know that, is really essential. And it also helps each member of the team know why we're approaching things in a certain way. So why we might recommend that the patient always has access to a newspaper, or maybe somebody's a huge reader. So we say, well, actually, to get over their delirium, providing books is going to be really important. So these key elements are important in the illness recovery, as well as just knowing a little bit more about our patients. Yeah, Jimmy, you're going to have to. Oh, thank you. So what have we done? So we recognised that before we had any major interventions, we needed to get organised. We have a lot of movement of junior doctors, and we had recognised our own behaviour as consultants, and that we sometimes got irritable at the way maybe our juniors were presenting patients. And we've already touched on the fact that the therapists would, be bogged down in medical information and not want to come to our MDTs. So Sean and I spent a little bit of time thinking about expectations. Were we training our trainees for working in MDTs? What did we expect from them and all of the other members of the team? And what did they expect from us in the MDT? So that was really kind of our starting point. And we discussed this amongst ourselves as a team for a number of weeks, really, and tried lots of different MDT reminders or checklists before we ended up with this final one that you can see in front of you there. We talked a lot about what was necessary to discuss, because again, there was this feeling of extraneous medical information in the specific MDT meeting. And we also recognise that although we don't want to get completely caught up in this just being about the MDT meetings, because it's not, it's about how we interact with each other throughout the whole working day. We recognise that how we behave in the MDT setting then translates through to the behaviours throughout the rest of the day between different team members. And I'm mentioning MDT, but our behaviour is the same at Huddle as well, because obviously we have these 2 meeting points in the day as a team. So we got organised and we put that huge sheet up that you see there in the office, so that everyone had that as a reminder in terms of what we were doing during MDT and what was to be expected. And then we formally set out in specific interventions from November the 5th, and we divided these into 3 sections, as you can see. So better teamwork and communication. We're very lucky to have a big MDT room on Ward 14. I must make this clear that if we are consuming anything, we are 2 meters apart with good ventilation. It is a big room, so not all wards will be able to do this. We introduced some icebreakers. We're not doing this every week necessarily, it depends who's on the ward, but certainly if we've got a different team of junior doctors, we try and make them very much feel part of the team for that week by getting to know people. And we've had different icebreakers, so knowing a little bit about each other, right down to what did everyone have for breakfast this morning, just to get the ball rolling that day. Another major change in terms of teamwork and communication that we've done now for 3 weeks, and we're on our 3rd week now, is we've had a different discipline running or leading the MDT each day of the week. So, for example, we have the discharge coordinators leading MDT on a Wednesday. We have nurses leading it on a Tuesday. We have the physiotherapists delivering it on a Wednesday. I think I've got those days right. These are not quite concrete. I delivered it today, suddenly realised that there is 1 day a week where it needs to be consultant led. So that's been a dramatic change in the last few weeks, which people were nervous about initially, but is going really very well. And following the MDT checklist that we've got there, that ensures that all disciplines are included and are able to contribute to the MDT in a structured way. And one of the most important things around that was about current mobility. So as you can see, in understanding the patients, the ones there in brackets are ones that we want to work on, but we haven't yet. But what we have started working on is understanding the current mobility for every patient, and understanding that is shared knowledge, and that it's not the physiotherapist who says what that is, that actually the carers are the ones getting the patients in and out of bed every day. The nursing staff will be maintaining the mobility. The physios can't see every patient every day. So is everybody clear what the mobility is, so that we know when it's changed, either for better or for worse, and we can then have those better conversations with the therapists about actually need to get back involved, things have got worse. And then in terms of processes on the ward, so as you see, we've got the big A0 MDT pro forma on the wall, which is really helpful. We recognised that our EDAN board was tiny and tucked away in the corner, so we were able to move the boards around, so that's very centre stage now, and that's updated twice a day. We have started in the last 5 days, just this week, Sean and I take it in turns to ring the discharge coordinator at 4 p.m. and just see were there any discharges that were planned that actually something's happened in the day and the junior doctor has maybe made a decision, but maybe that's not the same decision as we would make, if you see what I mean, and that might be stopping the discharge. So we're communicating with the discharge coordinators to make sure that something hasn't just happened that we maybe as a senior lead would be able to say, do you know what, they can still go home and we'll deal with that. So we don't know the outcome of that yet. We've only been doing that for a few days so far. We want to develop a resource binder because of the turnover of staff, in particular the junior doctors, so that people understand what the processes are. But I'll come on to that a little bit in the barriers. So we could have the next slide, Jimmy. So you can see that J14 is one of the few wards in the trust that's had a step change in discharges before 3 p.m. We've maintained it, and I guess the thing is we had started the work before we started working in this work stream. So for a number of months, J14 didn't have a stable consultant workforce. Well, I say a number of months, it's probably over a year. I joined in about April. Sean then joined me in August, and we've managed to stay on 14 and be a stable workforce as a consultant leadership team since then, which has allowed us in a way that maybe other wards haven't been able to start to make changes way back then in terms of how the MDT runs. And so I think we can do even better than we're doing. I think that it'll be interesting, and some of our discharges before 3 p.m. are because we're very, very organised, but also because some of the discharges are delayed, and maybe we won't maintain this because maybe we get people out the same day, so it then becomes after 3 p.m. So that'll be interesting to see, but it shows that this can be done and can have a significant impact. Next slide, please, Jimmy. So what's going well? We've got so much sunshine, I can't even look at the slide. But what's going well is that it feels really different. You know, the last 2 years have been really difficult, and I think a lot of us had reached a point where coming to work was really hard, and we didn't enjoy it and kind of dreaded it on certain days. That's being fully honest. But now, even on the days where I think, oh, work again, another ward round, by the time you get to the ward, you feel really quite jolly because everyone's getting on well. There's a buzz about the ward. We feel engaged with, right, who can we get out? Who's sitting in the pod? What's happening next? Have we heard back from this person, that person? And everyone's behaving really nicely towards each other. MDT is much more slick and much more pleasant. We're measuring the timing of it because we're discussing a little bit more. Initially, the time went up, but we've brought it down. The MDTs are shorter later in the week. They're a bit longer Monday, Tuesday while we bottom things out. It feels like people are really engaged without us having to be going, why haven't you done this? Why haven't you done that? So we're not needing the stick. It's more of the carrot of the cake that people are responding to. It sounds ridiculous, but by 12 p.m. you're flagging after ward round, so the cake at MDT really helps. We've had junior doctors come to the ward who haven't worked with us for a while or had never been on our ward, who've just spontaneously at the end of MDT said, it's been such a pleasure working here this week. This ward's completely different from others. We really love the feeling of it, which has really given us that fantastic positive feedback to carry on. And we've had the same experience with physiotherapists who worked with us maybe 8 or 9 months ago, coming back now and feeling it's really different, and the feeling is different. Next slide, please, Jimmy. So we've still got to do a few things, well, lots of things still got to do. So we really need to still work on understanding that change in function for our patients. So sometimes it's still really hard to bottom out what was the patient like before, what are they like now, and get to the nitty gritty of that. And that being not just led by Sean and I moaning about it, but actually by people automatically doing that and wanting to understand that. We need to embed the understanding of life stories, and you know, that's something that the trust is working on anyway from a dementia point of view, but it really is essential. We're going to develop a guide for junior doctors on Ward 14 and a resource folder for processes, but again, Sean will come on to this on the next slide, the particular challenge around that. We're really keen to involve the healthcare assistants now. On previous wards, when I was on one of the wards where we were an exceptional team a couple of years, well, it must be about 4 years ago now, we had achieved a situation where we could bring healthcare assistants into the MDT meeting. Not all of them, one of them, and it made a massive difference, because actually they're the ones who are interacting with the patients all the time and notice little changes or notice that functional change, but the pressures on them at the moment from a carer point of view means it can't be managed. I can't manage it in my CCB either, actually, at the moment. But if we can't bring them in, how can we involve them so that their thoughts about the patient, what they notice about the patient, are listened to by us and valued? So that's going to be an important piece. And then not forgetting, obviously, patient and relative involvement and how we communicate with them. So this piece of work will take us a while and is very much still lots to do, but we're off to a start. So I'm going to let Sean speak about the final, well, what we think are the biggest challenges.
So, I mean, this has been really fun work to be involved in. Like Abby says, there's a spring in my step that kind of hasn't been there recently, which has been fun. But just thinking about kind of, obviously there's some practical steps Abby mentioned there, but I think there's some difficulties we're going to encounter in the future as well, in terms of getting to kind of where we would imagine you know, a great team and great kind of patient care to look like. Abby texted me last week to say having cake every day is having an effect on your calorie consumption. Certainly,
On my weight.
Yeah. So I've had to change about how I eat other things to cope with this. But it's only going to get us so far, isn't it? Giving people cake every day. There are difficulties. Like Abby mentioned, we still regularly turn up to the ward with a bunch of doctors that we've never met before, and that changes throughout the week, and that can be very challenging for junior doctors. I mean, challenging for us to come across all these patients who are really complex, but for junior doctors who are still trying to figure out medicine and what these illnesses are, being faced with a brand new set of patients who've been in hospital potentially for a while with lots of different things going on is very challenging. And when you do have some continuity of juniors, and you've got juniors where you're reaping the rewards of having trained them before, and that's really enjoyable. And likewise, continuity of patients, when you get to know patients, that's very enjoyable. But if patients are kind of shifted around the hospital, then, you know, after you've spent some time finding out that they did a PhD in their 60s and this is what's important to them, but now that they're on a surgical ward because they've been moved over there overnight, then you do lose some satisfaction. There's a big focus, obviously, in getting EDANs done. I remember, I was a leadership fellow for a vet when I was a trainee, and there'd been lots of talks about kind of how to do EDANs on time. And I used to always think, well, surely consultants just drive this. And I do genuinely think that. For my patients, I'd be very upset if people weren't doing EDANs on time, because I think it's just kind of the bread and butter of getting work done. But the thing that I feel sad for is, so I looked on the ward yesterday when I was doing this presentation. We'd had 11 EDANs completed for patients ready to go home. Those 11 patients are nowhere near going home. So from the junior doctor's point of view, I'm kind of constantly telling them off to get the discharge letters ready. And then they disappear to another ward next week, with the patient never going home. So you don't get any reward for the work that you're doing, because it feels like you've been given a thankless task to do, and then today we'll come up and say some other new patients come to the ward's going to need done. So that can be less rewarding. And then there is something about our processes. So what I feel a bit sad about is, I do think on J14 we provide really good quality care, we provide really good MDT care, we've got really good rehab going on the ward, to be fair, for an inpatient ward, in a way that I don't think was true when I was training. I think the quality of care in this hospital has gone up massively over the last 10 years, and I'm proud of that. But the difficulty is that when you get somebody better, and let's say they've been in bed for a few weeks and now they're starting to transfer and walk a few steps, we know that the best way to get those people better is to provide them further rehabilitation, ideally in their own home, but if not, then a kind of more suitable environment, which would be a CCB like Abby and I both work at. But for whatever reason, these things don't go right, and the patient ends up on a surgical ward or in some sort of discharge ward, and that can be very, very unrewarding to work in. And I think the other issue is we've got, as you all know, there's lots of patients waiting for packages of care or care homes. Some of them get stuck at our ward, and there's a social worker kind of loosely involved. And we discuss the updates every day, and what we'll be discussing is allocating social worker on holiday, a waiting D2A bed actually is changing to a package of care, and we're not involved with that at all. And that can be quite a kind of frustrating process for us. Trying to move to the next slide. I think this goes back to kind of our purpose, because I think we all became doctors to get people better, didn't we? I think, and to feel good about the work that we're doing, to feel good about looking after patients, but also feel good about working in teams. And for me, the other stuff, like I'm going to do what the trust asked me to do. I'm going to be like a good employee and kind of do the processes that are required of me. But the thing that gets you out of bed in the morning is getting people better, isn't it? And sorting patients out. And I think at some point in the future, and it is possible, because I do think that, for example, the elderly medicine wards, like I mentioned, are much better than they were 10 years ago. It would be nice to kind of have a process where patients are assessed really well in hospital, sorted out really well in hospital, and then get some proper rehab so that they can maintain independence and stay home. So geriatric wards have been shown to reduce the risk of disability and death. Only 33 patients need to go through one of our wards to avoid someone dying or going into a care home. But I've often wondered if those trials included discharge wards and D2A beds, because that's a very different scenario. Just trying to skip to the next slide. I'm just going to end with this. So I think some of this is well, this has all been based upon the kind of work that Ali was doing, and there's a kind of a fortunate serendipity with Richard's sort of the physiotherapist work on MDTs, but really kind of cheesy stuff, but important and stuff that you can get behind. So what brings us joy at work? What's going to make us happy? Well, knowing each other and working in stable teams is going to make us happy. Knowing our patients, knowing something about them is going to make us happy, and providing continuity of care for them. Knowing our processes and knowing how to move people through the system is important. Being organised, I think, is something that's the kind of easily fixable thing that I think to a great extent that we have fixed. I think we need to get all of this right to kind of feel pride in what we do as an MDT team, and I hope we're getting there, but I hope we can get there at some point in the future. I think that's the end of our slides.
Fantastic. Look at all the clapping there. You see that clapping? Fantastic.
I didn't know you could do that.
Excellent. Abigail, Sean, brilliant. Really, thank you so much, both of you, for that. Really good to share that at Report Out. I think an awful lot there worthy of our kind of reflection, and at some fairly fundamental levels of sort of human interaction, I think your presentation speaks to, as well as the very practical things you've done to improve that, and just some of the things you said about dreading coming into work, but because of the work you've done, that's no longer a kind of big black cloud. That how you described that, Abby, was very powerful. And also, I think I love the way you've got things like the physios leading the MDTs and so on. That's a really strong kind of message about collaboration in the Leeds way, the multidisciplinary approach, genuinely there. So really appreciate that, and very conscious after our conversation earlier in the day as well about the pressures you guys are under in elderly care, and it's great to hear you report that out. So we are quite up against it time-wise, so I was just going to move us on to the congratulations for our Lean 4 Leaders graduates before we try and squeeze in a little bit of a Q&A for those that can stay beyond the hour. So, Jimmy, if you don't mind, I don't have the list of our graduates in front of me. Would you be able to get that up so I can appropriately congratulate everyone?
I'm going to invite them to join the screen, Julian. I think I can see Sarah is joining us. I think I've seen Michael in the background, who's also representing his colleague Amanda Wilson, who can't join us today, but he's also in the same position. So, hi, Mike. I'll pass across. So I think I can see those folk there.
Is it just Sarah and Michael, Jimmy?
Who are joining us? That's my understanding. I will just check
right
back. I'll turn myself off and check back to make sure I've not missed anyone. But if I've missed you, put your hand up, and I'm sorry. Okay,
fantastic. So Sarah, Michael, welcome, and Catherine's put her hand up, Jimmy, as well. So Sarah, Michael, Catherine are Lean for Leaders graduates. Many congratulations to all three of you. It's no mean feat doing the Lean for Leaders, and I'm sure, hopefully, you've learned a lot during the process. If you can imagine, I'm handing you your virtual certificate. Really well done. The hours of work you've put into this, hopefully, you've found rewarding, and you're able to use some of it in your daily work, and hopefully sharing it with your colleagues and including your teams in that as well. So just any of you got any quick reflections on your experience or anything you wanted to say, report out? But, you know, brilliant effort and well done. Catherine.
Hi. Good afternoon, everybody, and thank you very much, Julian. My name is Catherine Sterling. I'm a pharmacist. I was just going to add to probably what Abby and Sean have been talking about at the beginning of their presentation, and just about the importance of listening to, you know, to understand and not to respond, and to learn that communication, that listening part that we covered quite a bit in the courses. But really meant I learned a lot and really started listening in a different way and not just to respond, which I think was really helpful for the things that we've been doing within anticoagulation. So yeah, that was my reflection, and really great to hear what Abby and Sean have been doing with their team on J14, which I covered there sometimes. It sounds great.
Yeah, fantastic. Thank you, Catherine. Michael?
I just wanted to say thanks to the KPO team for running the sessions. I know from me and Mandy, we've learned a lot. We've used a lot of tools, and it's really made a difference on SAU. So yeah, thanks to the team for all the knowledge.
Fantastic, Michael. Thank you. I mean, you're absolutely right about the KPO, but it's about the effort you put into it yourself, and you've done well to reach this point. That's great. And Sarah, I think you're on mute, Sarah.
Apologies for that. Just a comment that I think initially I thought I was mad trying to do it throughout a pandemic, but I think being able to use the skills, I work in children's, and we used a lot of the skills to link with adults, which enabled me to work with my adult physiotherapy colleagues, and actually to be able to support both teams. We've been able to take that forward. Those links are forged. So I think, although it seemed like a really daft thing to do it at a difficult time, it did pay off.
Excellent. Oh, it's really good to hear that, Sarah, because you're right in the sense that we were everyone so kind of full on with responding to the pandemic, but actually it's not stopped innovation, improvement and learning. So it's great to that you've made that point, and well done for completing it during an incredibly busy time. So well done to all three of you, and we'll also we'll ensure that if you've not already got them, your certificates, but warm congratulations to you all. So very quickly then, let's just draw breath and questions for Sean, Abby, or indeed any of our Lean for Leaders graduates. Claire.
I loved that presentation. I really did, and I loved your honesty and just the real focus on the patient that came through there. And that slide that you brought up, which had the bit about how the patient might like reading, or they might like to be dealt with in a more quieter way, all of that sort of real patient-centeredness. And if I were a patient, or if my family were a patient, I would want to be on that ward. But how do we make it so that it's not that ward dependent, that is how we deliver that service across that vulnerable group? And I guess that's the next step for me, because what a great, the experience that you're trying to give to our nurses, junior doctors and our therapists working on that ward, that's what will keep people wanting to come and work here and us have the, be able to provide that superb care that we aspire to. And I guess it's just how we then roll that out. But I have to say, I really, really enjoyed that. And I spoke to Ali last week about the power, or should I say Ali spoke to me last week about the power of team, and that just shone through absolutely brilliantly today. And I thank you for your leadership of that ward as well.
Thank you.
Thanks, Claire. I think you've articulated the point. It's not going to be an easy QI to roll out, because it's very much behaviour change, and I think that therefore we're trying to look at very specific interventions and measuring those, that actually it is the interventions themselves that then result in the behaviour change, rather than just expecting people to change their behaviour. And I'm sure Ali will say more on this, being the expert, but that's why things like even though we recognise the MDT meeting isn't the be all and end all, actually a bit like the huddle, how you behave in that setting. And we saw this when we did the huddle QI, and I was in one of the initial wards for that. You started with the huddle, but then the way that the team that's when we can start to think about spreading it to other wards, where we can say, well, this particular intervention, and then you see the behaviour changes.
It's a really, really powerful approach that I'm sure we can develop and spread. And well done, and thank you for taking this on and sharing this with all of us. I'm sure many of us will go away from this feeling, that much more kind of inspired and refreshed and determined to improve further. So many, many thanks. So congratulations to all of our Lean for Leaders graduates. Really well done. Great to have everyone for today's report out. Do pass the word on about report out. It is a great opportunity to share the work going on across the whole organisation and celebrate the improvements we're all making for each other and for patients, and look forward to seeing you at the next report out in a week's time, same virtual place. Many thanks everyone. See you then.